All right, everyone, I think we're just about ready to get started. I want to thank you again for joining us for this webinar from the National Association of EMS Educators. I want to take a quick moment to thank iSimulate for their sponsorship of today's webinar. iSimulate's a partner of NEMSI's offering high-quality simulation products that can be a huge difference maker for you and your program. I'll include information in today's follow-up emails for you to learn more about iSimulate and to get in touch with some of their sales reps. Today, we're joined by Katie O'Connor and Michael Kaduce from UCLA. Katie and Michael are going to be providing tips, best practices, and advice for implementing physical distancing guidelines in your lab environment. Today's webinar has been approved by CAPC for 1 hour of continuing education credit. Tomorrow morning, you'll receive a follow-up email through Zoom. This follow-up email is going to include a bunch of information, including links to nemsi.org, where you'll have the opportunity to provide your full license information and register for a certificate. I just want to notify you that for NEMSI members, this certificate is free of charge to anyone who's in attendance of this live stream. For non-NEMSI members who attend this live presentation, there will be a charge of $25 to obtain a certificate. If you have any questions about the CEU process or how to obtain your certificates, please reach out through the nemsi.org contact portal. During today's presentation, we encourage you to utilize the Q&A function and type your questions into the Q&A panel on your Zoom screen. We'll be collecting your questions and then answer some of them throughout if we can address them, but we'll have a Q&A session at the end of today's presentation where we'll be able to deep dive into the questions you posed throughout. I'll repeat all of this again at the end of the presentation, so this certainly won't be your only opportunity to get this information. But for now, it's my pleasure to hand it over to Katie and Michael to talk about adapting your lab for physical distancing.
Thanks, Nate. Really happy to be here. Michael and I have been working on this, bringing the students back to the classroom, I think since like before we even stopped having labs, and being at a large institution like UCLA and in a state with a lot of regulations like California, it's definitely been a challenge. So we just want to share with you guys what we've been able to work through, some of the ideas that we came up with, some stuff that we didn't think about until we'd already gotten halfway down the track. So that's the goal of this. If you guys have questions, please let us know. We're happy to answer them. And really what we're doing is sharing all of the stuff we compiled. So a lot of this is stuff that came from other EMS educators or from our colleagues in nursing or the School of Medicine, our infection control docs at UCLA Health. So really thanks to them. We're just putting it together and putting an EMS spin on it.
Absolutely. And I think we're just super excited to be able to share kind of what we've come up with. I think we have to recognize the World Health Organization said very early on when the pandemic started that we have to have the healthcare providers who can treat the patients that are suffering from this, who can track this. And we recognize that we have to be able to continue educating, doing research, evidence-based practice, and developing what's going to come next in this pandemic.
Yeah, and really it is a pandemic, and we know that without a vaccine and without other things, we have to rely on physical distancing, and we know that's really important. We've seen it work. We want to be leaders in the forefront of this. We don't want to be people who are like, well, our class is important, we just want to get done, we're not going to abide by those guidelines. That's absolutely not where we wanted to stand. We wanted to stand with the experts, with WHO, CDC, our governors, our public health experts in Los Angeles County, and deal with this physical distancing. But at the same time, as Michael just mentioned, we have essential personnel that we need to train. So how do we stick with the standard guidelines of working remotely and washing hands and staying at home and being 6 feet apart and still get these people prepared to go out into the field? No hugs and handshakes, that seems pretty easy to implement. But for us, the remote work and 6 feet apart, and here at UCLA, avoiding crowds is not our standard practice. We have 50 students in our paramedic program. Michael, you have like what, 100 and something in your EMT hybrid program?
Yep, spaced out throughout a couple different days, but our biggest group is 60 students.
Yeah, so definitely we fit the characteristic of large crowd as our normal. And we know that in order to get through the program, they have to acquire psychomotor skills. And we were finding that we could do a lot of stuff via Zoom. And I had another presentation about how we adapted a lot of our simulations and scenarios, and those learning objectives were really well met. But we found ourselves not being able to really meet a good learning objective for the psychomotor skills acquisition. We could get them to imitate and manipulate. Mike even came up with a great at-home oxygen bottle so they could practice that, but it doesn't really get them to the place we want them to be at with precision and articulation, and definitely not in close to naturalization if they've never put their hands on some of these tools before.
I think that's so important in the conversations that we've had are, if we have to bring students to class, we want to bring them back to do the things that raise the bar. We need them back to focus on the things that they can't do online, and get them prepared to go out into the field. We're going to keep everything that we can do online. So when we are back and when we are taking that increased risk, we're going to do what matters.
And so to that point, what we did a lot of is we put out our skills sheets to the students so they can start memorizing them and getting to know the steps of the skills. One of our paramedic instructors at Oliphant has a document camera set up. So he's having the students walk him through the steps. So they're watching him physically manipulate the items, and then anything that they can practice with at home they're doing, so that we can limit the time that they have to spend in lab by getting through some of these hurdles quickly online, and then really bringing them back for the stuff that matters, which is the top of our pyramid here. So how are we going to do that? Well, we thought about it as a group, and we said that our main considerations were we only want to do it if it's safe. Safe for our students, safe for our faculty and staff, and safe for our community. We wanted to be compliant, not that we wanted to, but we kind of have to be compliant with all of the regulations. That's the local, state, our institutional regulations. And for us, that's a lot because we have School of Medicine, and we have the school, and we have UCLA Health. So they kind of sometimes are a little hard to be compliant with everyone. Plus, of course, being a paramedic program, I have to worry about COA. Kaduce, you have to worry about the state regulations for EMT. And then for, as we mentioned, it needs to be worthwhile. So if we're gonna bring these students back and we're going to expose them to some risk, because we know that we can't get to a place where there's no risk, that the risk has to be worth it. It has to be something that they couldn't do otherwise. And for us as a paramedic program, as soon as we made all those things and said, oh, we're totally gonna do this, we then looked at what we normally do as normal practice. And you can see this is a picture from our camera systems of multiple skills rooms. We do not practice social distancing or physical distancing at all in our skills. Normally we have like 7 or 8 people in a small space, all working on the same pieces of equipment. And I'm lucky if I can get people to wipe stuff down at the end of the day, let alone in between different skills groups. So definitely we have a long road ahead of us to get from our current practice to something that would look safe and worthwhile and compliant post-COVID. So we created an action plan of how we're gonna go from definitely not okay to yes, signed off by everyone. And the first thing was to look at all the institutional policies and orders that are already in place. Michael's been leading our COVID task force here at UCLA, and he's done a great job of pulling our CDC recommendations, the UCLA guidelines, and our local county protocols from our EMS office there, and really putting them together every morning for us in our briefing so that we can see how things change. And that's the one thing that's been really certain is the uncertainty of how the guidelines are coming out, what dates and times, when we're reopening, when we're not reopening, are we going to be at stay home or not? So we've just been trying to be fluid with that and keep up to date so that we're not creating a policy for something that was changed already by somebody else. And then we need to create a plan to implement that. So that's what we've been working on for the last couple of weeks is our implementation plan. That involved stocking up on supplies, which we have to order through our command center at UCLA Health, since they are supplies that are in demand for both the clinical setting and for all of the educational programs here. We had to prepare our space, which in the paramedic school involved cleaning out all the leftover Chipotle that students had left in the fridge thinking they were gonna come back to school the next day. We needed to message the students and let them know what the plan was and get them ready for the expectations that we're going to be putting on them because stuff is new. And we had to train our staff, and hopefully we're going to get back to the lab, which luckily the EMT program has been able to do. Just another plug here. You don't have to do all of this on your own. Really, you should be finding policies from other schools or your other organizations. If you're in part of a college, I'm sure your nursing school is working on this, your other allied health programs. Just crowdsource, get policies together, and that'll make it a lot easier. And then everyone will be on the same page, which is especially good if you have students in multiple programs.
I think one of the biggest things that we've done, and as we've put all of these briefings together, is rely on, as Katie said, our friends, our partners, and we've collaborated. We've worked with our simulation partners, and Katie's actually now on the simulation committee that's working on these guidelines. We're using our resources at the School of Medicine, the Department of Nursing, and the School of Nursing are both working. They want to return their students as well. Internally, we have a phlebotomy and EMT program. The AHA training programs are becoming even more important important. We have to train people in CPR, and eventually we have to renew all of these certifications that are going to expire. We've also relied, the hospital and the health department has really relied on our infectious disease experts. I think if you're working in a hospital, recognize that you have these people that understand a lot more about this and can help give you some guidance. So it's not just, this is the Katie and Michael show and plan. This is actually what the experts are telling us is working, and we're taking different ideas and saying, hey, this is the challenge we have to overcome. How can we do it and reasonably, logistically plan for this?
Yeah, so we had a great collaboration, and everyone comes at it from a different lens. So one of the things that our School of Nursing colleagues pointed out was, in our documents, we link to a lot of things that are available if you are a UCLA employee or student, or you have access to the UCLA network. And some of their nursing students weren't part of UCLA Health's network, so they weren't actually able to get to our online training on donning and doffing PPE. So that was something we had to move to a different platform so everyone could access it. The Simulation Center also brought up different guidelines for cleaning mannequins, and their sim tech there had a wealth of information on which mannequins could and couldn't be disinfected based on their manufacturer guidelines. So he's able to create a document for us that helps for some of our instructors who maybe don't do mannequin maintenance regularly, or maybe we're looking for different supplies because our normal cleaning products are out of stock. So it's been really helpful to collaborate across the board. So first thing was, how do we make it safe? So we know that physical distancing is key, and we wanted to, whenever possible, keep 6 feet between students and staff. So a collaboration of all of these really smart educators and experts came up with some things that we're saying, okay, this is safe, we should be doing this. These are things that we're like, nah, maybe we need to be careful, or upper level of PPE or limit, and then definitely things to avoid. UCLA made it really simple for us. You're not allowed to lecture to a classroom full of people. So we are not coming back to the classroom, and we know that a large group just sitting static for multiple hours in the same ventilation system is linked to large spread outbreaks. So we wanted to not be those people and not have our names in the news for anything but awesome education, not getting everyone sick. So we're gonna not have large static classes. We know that eating and drinking is a time where they can't wear their mask, which would increase risk. So we've closed our social areas, our kitchen, and we've moved to outdoor seating that's spread. Luckily in Southern California, we have the weather that accommodates that. So that was something we could use to our advantage. And then we wanted to stop any aerosolizing procedures. So for the paramedic perspective, we know our students know how to use a non-revealer mask. Before COVID, we saw all of our current cohort do that. We've actually practiced CPAP with oxygen. There's really no reason for us to now add oxygen or compressed gas back into the skills. It's just gonna create more opportunity for aerosolization, so we're just not gonna do that. And instead, we're gonna focus on training to the non-aerosolized procedures that are currently being used in the field here. So instead of using a small volume neb, we're gonna use our metered dose inhaler with a spacer and have that as our competency, because we don't need to do any aerosolization. We're also limiting extra people that are coming. This is one that's kind of hard for me. I think if you saw some of my other presentations on simulation, I'm a big proponent of the simulated participant. I think it adds so much to the affective domain for our students and really gets them into the assessment of the scenario. But we're not here to do assessment, and we're not here to do affective stuff. This is the psychomotor skills acquisition that we need to work on. So if we want to take those learning objectives and move them to Zoom, where we can have zoomed in virtual patients from everywhere, that's a better choice for us right now than to try to bring in our geriatric patients to a potential COVID positive group of students who are currently working in the field and not sure if they're symptomatic or not when they come in here and are fake treating our healthy geriatric. So we're gonna not do that.
I think we also recognize that this posed a logistical challenge for both students and staff. Having lectures online and coming to class for skills, for some of our programs, that's a whole day. There's a lecture potentially in the morning and skills in the afternoon. We had to do some planning of our schedules and look at that. We worked to minimize that as best we can. So if they're coming to class, they're coming to class in a small group, and then they have time to travel. If there's a lecture in the morning, maybe it's shortened, or we're not doing a full day of skills, we're reducing that and supplementing with lecture, online activities, things like that, because it is logistically challenging for students to get to class in an hour, especially in Southern California. And as traffic starts to pick back up, that's a real concern that we had to start working on and planning and really looking at our schedule to see if there was a better way to do it.
Yeah, and the other thing is when we're thinking about what we're limiting and doing, there's definitely a part of this where we know we have certain skills that we have to do. So we want to be cautious around those and just realize that that's a higher risk. So just like when we have live phlebotomy lab here at UCLA, we have 2 instructors, or we decrease our ratio from 1 to 6 to 1 to 3, because we know it's a place where there could be potential dangerous activity happening because we're doing live stick. So we're gonna do the same thing here, and limit or be aware of the fact that when we're doing things like CPR in a group, we know that even in a clinical setting with a fit tested N95, CPR is a motion that causes your mask seal to be released. It also increases your respiratory rate and effort, so you're going to be spreading more aerosolization. So even with face masks, and I don't know about you guys, but I have been struggling for weeks now trying to get mine to stay in place without sliding down. So I can't imagine trying to do compressions and it's sliding down. So for sure, something that we were just thinking of, we want to do this, we think it's worth the risk, but we know it's a higher risk. So we're going to be cautious with those activities. And then everything else we can do distant. So if we do want to run a call and have a simulated team, we can have 3 different setups where each member has their own set of equipment, and they're working together in a large room with one instructor watching. That way they're distanced, but they're still communicating with each other. And since they can't actually see things, it actually adds into our communication dynamic of getting them to use closed loop communication and really speak to each other. So we're getting some of our other objectives met around communication, culture of safety, med check, all of the stuff that we sometimes struggle with generally. So with our group, we came up with everything that can be distance will be distance as our guiding principle. We're going to pre-screen participants. So Chris O'Connor is mentioning in the chat, great last name by the way, that they had their faculty and students complete a declaration. They were asymptomatic. That's what we're calling pre-screening here. And I have our declaration or our page to share with you guys. In LA, we have universal masking. And so we're going with that policy. And it's just a cloth face covering. And it's provided by the students, but if they don't have it, we'll provide it for them. Permissive use of face shields. This is at the recommendation of our infectious disease specialist, that they don't necessarily have to have universal face shields, but especially in those skills where they're closer together, or students who feel that they have an increased risk of exposure should be allowed to wear face shields. And it's permissive for both the student that's participating and the potential simulated participant. So if you had 2 students checking blood pressure, either of the students could request that they both or one have a face shield. It's just completely permissive for anyone who wants it, but not required. And then we really want to make sure that it's a safe learning environment for everyone. And that's a psychologically safe space and a physically safe space. So since everything that can be distance will be distance, we have to get used to the fact that Zoom is here to stay, and that the face mask and face shields and cleaning things are probably going to be here for a while too. So moved a lot of our learning objectives online, and then really focusing on the small amount of stuff we have to do in person. So this is where we had is it worth it to bring people in? And like most of you know, CPR skills are something that we just can't get accomplished remotely in a easy manner. There are a couple apps out there, it's been trialed, just really difficult. And for us to combine all of the requirements that we have at the paramedic program and at the EMT program, it just makes sense to do that in person, especially for compression depth, rate, quality. We also felt strongly about medication administration before we send students to clinical. We want to make sure that they can handle it safely and safely use sharps and dispose of them because it's a high risk procedure. And then we also are battling with COA requirements. While they're still saying that there's a lot of things you can do with SIM, there's also stuff that they have to do before they could go to a clinical environment and get checked off. So we're gonna make sure we have that done and checked off before we send them on. Our clinical sites have added new requirements for donning and doffing of PPE training. So we just want to make sure that we're training them the same manner that the clinical sites are using. So we're updating that a little bit before they go out there. And with the clinical sites donning, doffing training, we're using videos and then in-person training with a PPE watcher, which is what our sites are doing here. So we're planning on having them have a PPE watcher who could signal if they've done something wrong or done something incorrect or could get better, so we can actually see them do that. And then some of this is just to fill in a gap. So we know that a lot of places, the states and COA and National Registry are allowing virtual training, and they're allowing simulation in place of some of these clinical rotations or experiences that are now locked out for students. So for example, our paramedic program is locked out of the obstetrics and neonatal wards. We don't know if it's for COVID or if it's just they're taking the opportunity to keep our students out because they're never used to be super friendly to us. It's always a very hard space to get into. And now it's really difficult. And we don't see that even opening up till way past September. So to get our students the OB contacts, we're gonna have to use simulation, which means we need them to come in and do small groups. So it's definitely something that we can't get in any other fashion. And that's gonna be one of the things we use the small group learning for.
And I think on the EMT side, where we've reduced our use of clinicals, just simply because there's some requirements that are no students are going into the field right now, and just the reduction in our agency partners. So we're really trying to supplement that with a higher degree of fidelity in the classroom, including simulated participants. So we give a student the vital signs and the chief complaint, and then a fellow student completes the assessment. I think we're trying to increase those so that we feel our students are prepared. And one thing that Katie said that I think really hit us is we're trying to figure out which skills are most important to be done on site. We recognized that actually tourniquet application was one of the easiest things to do on Zoom. The number of people that I saw use put a tourniquet on a foam roller, a lamp pole, just anything that they had that they could do a tourniquet on and make a tourniquet out of cloth. We provided them instructions on how to do that, told us that, okay, we can reduce the risk of bringing them in to do that. So cool, we can complete that skill online. We can check competence. We feel confident that those things can be done online, so that we just need to bring them back for those things like Katie said, OB simulation, on the EMT side, very specific medical trauma simulation, things like that.
Yeah, and again, we're starting this from the perspective of trying to be safe, not only for our students and our faculty, but also for the community. So there is a worry that if we tried to force our students a lot of them are actually out working in the field, and a few of them have had occupational exposure to COVID. One is currently ill. So we know that for us, it's a real reality that our students could be coming to clinical rotations or going to field rotations or coming into the classroom and potentially be asymptomatic carriers. So we don't really want to have them around maybe neonates or geriatrics or at-risk populations. So for us, doing a simulation seems to be a better choice for the patients that we're taking care of than potentially exposing them to our students who may be asymptomatic carriers. We also found that simulation can be more effective than some of the clinical hours. So if there's a low census at the hospital because the students aren't allowed to see any of the COVID patients, doing sim can actually be a better use of their time. The link here on this slide is to some data around how simulation can be a little bit more effective hour for hour than clinical experience from our colleagues in nursing. So if you'd like to look at that research study, they've been looking at it for a while. Nursing programs typically have a 2-to-1 or higher ratio of simulation to clinical hours. Not something that's really common in EMS, but maybe it will be in the future. So when we talk about pre-screening and trying to reduce risk, because we do know our students could be carriers of COVID, we looked at what the disease experts are recommending, and it's really UCLA modified, but very close and similar to the CDC guidelines for return to work. So we're looking for anyone who has any potential symptom of COVID, you're just not allowed to participate in our classroom. I've shared with you here via this QR code the return to work guidance document that really outlines it for the students and staff returning to work, and then they sign that as their declaration or attestation that they don't have those symptoms. We move a step further, and we are actually temperature screening at the door. So we have staff that are waiting outside the classroom space. to temperature screen everyone who's coming in. All of our staff are temperature screened as well. And that's just with policies that UCLA has set forth that all of the buildings coming in and going, people will be temperature screened. And for us, that's going to help us just kind of make people choose the right choice, right? So I know in my history of being an instructor, there's a lot of times where students come to school sick. I've come to work sick. I have gone to school sick. It's that like deadline that's facing, or you're afraid you're going to miss content, or you're close on hours and you don't have any more sick days left. That really encourage people to come in sick. So what we're trying to do is set a really hard standard of, hey, if you're having any symptom, if you're sick in any way, just stay home. And then we're backing that up and being student focused by creating policies that are open to people making up time, which was never something that UCLA paramedic program allowed before. It was, if you missed a quiz, if you missed a session, you better get notes from your colleagues, because we're just moving fast. Like next day's new content, we don't have time to make stuff up. Now we're saying, hey, we'd rather be safe than sorry. We'll work with you. If there's a reason why you can't come to class, let us know. Don't come to class sick. Don't try to take Tylenol to block your fever. We want you to stay home, and we will get you the materials. We will get a makeup. Everything will be okay.
A couple additional things I think important as you're planning your return is, because we've seen this, we have one student who's living with someone who's immunocompromised, and the student has made the decision they'll not be coming to lab. We want to be supportive of that and provide the student the resources that will be necessary. I think that's a conversation to be had with the specific individual in terms of that it may not be safe for 6 more months for that student to come to lab. So how do we work with that student to still make sure that they're getting the information that they need, or can we work with them in a virtual environment? We have another student that's roommate tested positive for COVID. So that student, again, in a couple of weeks may actually be able to return following our return to work guidance, symptom tracker, things like that. So that's a short-term solution. Can we enroll them into another class? Can we put them into just the next class that comes around for skills? But I think there's some conversations to be had with students who it may be a while before they feel comfortable and are able to return to class. So I think those are conversations to be had. We've seen it happen and we're coming up with solutions, but as you're planning, that's something to have a thought about. What are we going to do for students in those situations?
All right. So 6 feet apart, we've got stickers and signage from our building around. We've also marked off tape on the floor of our classrooms. Kaduce is great. They're using the stairs instead of the elevator to keep people 6 feet apart. And the way we started this and figuring out how many students we could actually bring back at a time was to look at the square footage of our space. Dr. Davis shared with us this space calculator. So I've got a QR code there. I think it's for banquets, but it actually, you can either pick how many people you have and how much space you need, or how much space you have, and then it can tell you how many people you can accommodate. And that helps us get a grip on, okay, we can only bring this many people back. Well, we don't think it's valuable to have students in groups of 2. We really want them to have groups of 3 or more. So 3 plus an instructor gets us to 4. They can't be in that small classroom. It's way too small for 4 people. So then we're just not going to use that room, because we've decided that it's more important to have a larger group in a bigger setting. And generally speaking, what we've decided is that a group of 5 is kind of higher risk, and they can be doing smaller activities that are closer together within 6 feet range. And then if we want to have larger groups, up to 10, they need to be distanced by 6 feet. And really, we don't want to go over 10. It just seems too risky for us, because our building really can't accommodate, while we have large classrooms that we can have hundreds of students in at once, the bathroom doesn't really allow for that, especially at social distancing. And our hallways and elevators and stairwell spaces don't accommodate that large of a group and remaining distanced. So we want to keep it to small groups of 5 and maybe up to 10 in their own classrooms with very scripted kind of changes. Kaduce, you want to mention your doorway?
Yeah, actually, one of the things that we found was that giving students a pathway is important. So when they do a skills rotation, we have them follow a certain door. So there's an indoor and there's an outdoor that allows them not to meet another group in the doorway and run right into each other, limiting that social distance, but also just limiting the amount of air circulation in that area. So I feel a little bit like I'm a first grade teacher in terms of having staff lead a student. Certainly for the first couple labs, we have to kind of show them the route. We've debated putting tape on the floor, but found that actually just leading them in the right direction works just as well. Then they're not collaborating in the same space, keeping out of the lobby. We made some other recommendations in terms of breaks are acceptable to students as they go. Instead of having a break time where all students go and use the restroom or the drinking fountain, we know that that's going to run a huge risk of having lines form. So we've eliminated that. We've also put instructors in different areas. So when class first starts, we have someone taking their temperatures outside, but then once they get to the top into the lobby, we have another instructor standing there saying, hey, this is where you're going. This is the lab you're going to. So you're going straight into your room instead of collaborating in the lobby or collaborating into a, everybody kind of meeting in one area. We're sending them directly into their small groups. So we prevent that standing around, being close to someone, and then just getting them into the right place. We also shortened, we put a little bit of a different end time on our classes. So we've put some free practice time at the end. What that does is it allows students about 25 minutes to leave the building. So instead of all of them leaving at one time and accumulating in the stairwells, we say, okay, you've got practice at the end for 20 minutes. What we've found is that about half to 2/3 of the students will stay and practice and then kind of trickle out once they get the skill done that they need. Some of them will all leave at the end, but it's usually small enough where they can still social distance and get out of the building. So we've done some things like that to try and be a little bit more creative in preventing the students from getting too close to one another.
PPE was a really challenging thing for us, one, because we know that there is still a shortage, and it's a real concern for us here, even to the point where when we are practicing proper donning and doffing, the request is to not use real N95s, but to use a surgical mask or a face mask and just explain the differences to the students, because it's not, we just have too much of a shortage, and especially if we're going to see a surge like we're seeing in some states right now, and the experts are suspecting will happen in a second wave. Our supply chain just hasn't gotten to the point where we could use the PPE the same way that we might have in the past. And some people are mentioning in questions like, what is the cost here? Cost is a serious concern for us. We had a lot of programming that was canceled, and that's revenue that we would have normally been expected to get in. So we sometimes already spent it, which is not a great situation to be in. And if you're in higher education, you probably know that this is not a great time for the budget. So thinking about how PPE has increased in cost, how we really want to focus on making sure our clinical providers have what they need and not take it away for training. We decided that we're going to use universal masking, but it's going to be cloth face coverings that they need to go to the grocery store or they can get from home. We have some that we will provide to students and they can bring their own. And then we have some face shields and face protection that'll be permissive if students want to use it. And our PPE, the data that we're using behind that, one of the studies is linked here on this slide. So that's what we decided. We also wanted to be really careful to make sure that we weren't doing something that maybe saved us money or saved us supplies, but instilled the wrong message to students. I've been working really hard here at UCLA to make sure that we change the paradigm around glove use so that they're not just wearing one pair of gloves all day to simulate gloves, or some kind of magic scene safe BSI, I can't fail if I'm always wearing gloves nonsense. We saw that that translates to the field, and gloves are actually one of the ways that diseases spread. So we're opting here to purposely not use gloves in simulation, to not waste them, but also to not have students wear one pair from multiple simulated patient to multiple simulated patient, so that they develop a habit of just wearing dirty gloves around all the time. So that's a choice we made. It may not be the one you make, but that's where we're at with our PPE discussions.
I also think important to note that wearing the PPE correctly seems to be, people are willing to put it on. I think one of the biggest things we find as we're rotating through, making sure everyone's doing it, is make sure their face shields are worn properly. It's easy to wear it high on your forehead, at which point in time it does you like no good at all. And same thing with masks. We're just trying to make sure our instructors advocate for good use of the devices. We can send them the videos, we can do the training, but if we're not circulating through the classrooms and enforcing the rules, but just advocating for good usage, that's one of the things that we're coming up against. So making sure they're wearing it properly once they do show up with it is the next battle.
Cleaning, man, if you guys could hear my battle cry for cleaning before COVID, you can tell I've definitely now even gotten on a higher podium of just clean the mannequins, clean the equipment. This is something we don't do well or we, at least our program, didn't do well prior to COVID, and now we know it's a real problem. So we have to change a culture of even requiring people to reclothe our mannequins or take this electrode stickers off of them at the end of the day and wipe them down, to, hey, you really need to be wiping them down in between each student interaction, definitely in between each student group. We need to wipe them down at the beginning of the day, at the end of the day, just to make sure. And then some of our mannequins are just not easily cleaned. So either the manufacturer recommendations are not to use soap or harsh chemicals, or they're just difficult in general to clean. So we're trying to use mannequins that are a little bit more friendly to cleaning and less likely to be something that could spread stuff around. One of these examples is we're going with the American Heart recommendation to not do any type of mouth to mask training, because the lungs and the mannequins are just something that's really difficult to keep clean and to not spread germs. So we're not doing any mouth to mouth or any mouth to mask training, and not using any of that type of equipment.
One of the things we're also doing is, I would say, making sure your instructors are cleaning between uses. It's really easy to think that it's getting done, but until you're out there in your lab making sure it's getting done. We actually did a couple things with our students where if they were, for example, doing CPR and we require that they skills track that and do 5 attempts of it, that instead of doing 1 attempt and then switching with their partner and then switching again, that student will do 2 from top to bottom CPR demonstrations or skills, and then we'll wipe the mannequin down, we'll switch their partner, we'll do 2 more. That eliminates a little bit of the risk of transmission. It eliminates the use of supplies for cleaning quite as much. But if a student can practice on one mannequin a couple times, then switch, and their partner does it a couple times, it helps move things along a little bit quicker, but also recognizes that there's less supply need to clean mannequins.
Yeah, and I say just overestimate the time it takes you to clean. So one of the things in our policy that's coming from the Sim Center is that you only schedule enough students that you have time to clean between student groups. And as a lot of you mentioned in some of the comments or chat, there is a staffing concern. So if you aren't able to hire more staff to do this, then you may need to just give yourself more time in the day. And that's like a realism that you'll have to explain to your administration. But if they come and help you one day trying to clean up these mannequins or clean the site, they might actually be able to see what it's like and how much work it is on top of all the work we're doing as educators. And then Dr. Davis is jumping in here to remind us that proper hand hygiene is really important. So for us, we had to add soap to some of our sinks. So strangely, our building, all the sinks don't come with soap. So we just wanted to make sure we had soap available at each place, and also like paper towels and things to clean their hands with. And then making sure that we have more time, more breaks staggered so that students can perform proper hand hygiene in between their rotations, or in between when they're taking a water break or a food break or something like that. So the next thing we're going to talk about is student messaging. So we've created all these policies, we've thought about it, we've tried to be student focused and think about all the things that we'll need to be flexible on. But we really need to message this out to the students so that they can understand why we're making these changes. A lot of people are mid-cohort right now, and what the students signed up for is not what we're able to provide, right? Things have changed, not through the fault of us as educators, but because of the changing dynamic of being in the middle of a pandemic. So we want to be open with that. And we want to explain to them early what's going on, what expectations we have, especially if you're bringing students back to lab. I know in our program, we have a bunch of students who relocated when we shut down our in-person classes. So some are on the East Coast now, some are up in Northern California. And others just don't have a place to live nearby. So if they were going to have to commute, it's like a 3-hour commute, and that's not really feasible if we want to have them back 3 days in a row for an 8-hour lab day. So we want to communicate early and often. They tend to get a little wound up when you don't provide any updates or any information. So that saying no news is good news, not really true in this situation. Even if you're not able to bring them back or you haven't figured out what you're doing, giving an update saying that you're working on it or this is the direction it's headed, I think is helpful. And then lastly, you should reflect the reality of the situation in your notice to students. So I would be open with them that this is a changing paradigm. Like, we don't know what could happen in the next week or month. We, as an example here, we had all of our students ready to go back to fields because we thought, okay, great, COVID risk is down, the field sites are ready to have the students back. And then we end up with a bunch of civil unrest. and now the sites are no longer willing to have the students there. So I don't know what you guys have on your 2020 bingo card, but who knows what's gonna happen in July. So we're just gonna keep our language to, this is what we're doing, this is the information we have right now, this is our plan, but hey, you guys have been here with us, you've come along for the ride, you know that things change pretty quickly, so just keep that in mind. We're also planning for contingencies, right? So we're bringing students back in groups that we can handle with a little bit of a buffer, so that if one of our clinical sites shuts down or we don't have staffing, we can't get a clinical instructor because maybe they've been pulled back to the field for more civil unrest or more COVID patients, whatever it could be, that we can staff it in-house. So we are really looking at how can we ensure continuity and message that to the students that that's our goal.
And I would echo the messaging. Student messaging is important. Don't forget about your staff, your clinical instructors, the part-time adjuncts. Many of these people have picked up shifts on their other jobs that are keeping them busy. So what we recognized was, gosh, we need to very clearly communicate when staff are going to return to their shifts. We've tried to cancel shifts when needed and things like that, but we want to keep them in the loop. We also want them to feel safe coming back to work. Their mentality of, or what they remember happened 3 months ago is going to look very different when they come back to work this time around. So I think that's another thing. Make sure you're keeping your staff in the loop. We send out a weekly, just, hey, this is what happened this week. How's it going? And when the pandemic started, we recognized the need to continue kind of that while we're physically distancing, we want to be socially active. So we started doing video messages and things like that to make sure that our staff knew what was going on. We're up to date on anything, even the weeks where it was like, hey, there's really nothing to tell you. We still sent out an update, just, hey, we hope everybody's doing well, hanging in there. Just tried to share we shared pictures of new pets and things like that, just to keep staff engaged as well.
Yeah, and then I think that one of the things we were really trying to do is be flexible. So we're setting reasonable expectations for what the students would come back to, but some of the examples we've used already, students who live with immune compromised people or have had to move or maybe don't have the same living situation that they had at the beginning of this, or potentially now they don't have the same financial situation. I know a lot of our students plan for how long the program lasts, and that's how much money they have, and they are banking on getting a job at the end of this program to get their finances in order. And now we've added months extra to this, with some of them not even able to get jobs because of hiring freezes at places. So we're just trying to be flexible around those expectations.
I think one of the other things we wanted to focus on too is ensuring that everyone is safe and it's a safe space for them to come to class. To address that, besides some of the physical barriers and things like that we put up, hand sanitizer, hand hygiene, stuff like that, we also wrote into the student acknowledgement that the students had to sign a mask shaming clause, in that no one will shame someone for wearing a mask or not wearing a mask. We recognize that while they're in class, they have to wear the mask, but if they were to leave the building and go outside and take their mask off, we certainly wouldn't want anyone to give someone a hard time about that or harass someone about that. And the same goes for someone that is wearing a mask. We wouldn't want that to go either direction. So we spent some very quality time drafting some of that language to make sure that our students felt like they were in a safe space, that they were able to come back. I think we also recognize that there's some fear and some anxiety out there about coming back to small groups. We've spent a lot of time hearing that returning to big groups of people is dangerous. A little bit we've done with that in terms of just messaging to students what it will look like when they come back, but also recognizing that if a student it has some of that anxiety, has some of that fear, we may need to come up with a different way to address their skills performance in a different environment that we normally would be, and just acknowledging that that's something we need to prepare for, that's something we need to have a plan in place for.
Yeah, exactly. So like it may be your program's preference or standard operating procedure that students check blood pressures on each other to learn how to do blood pressure. But if a student is either immune compromised or feel that they're at higher risk, you should give them an option to try to do that on a mannequin, or do it with even like a computer speaker with core cough sounds. You could do that now too. iPads will actually play them. So there's all sorts of other options that we can do that wouldn't put a student who feels that they're at higher risk in that risky situation, even if we're minimizing it with masks and face shields and hand hygiene. We do want to just be respectful of the fact that everyone has underlying health conditions or people at home that they're concerned about and maybe just aren't able to take the same risks that other people might be. So we want to make sure that it's physically safe and psychologically safe for everyone. So this is where we landed. So compared to our shove everyone in a small skills room around a bunch of tourniquet legs, this is actually, I think it's Michael teaching in the EMT class with them getting ready to do blood pressures, actually.
Yes, exactly, Katie. And actually, the easy way around this was a big room. This is a group of less than 10 people. And we just put the chairs out 6 feet apart. I think just things that we discovered was students will move the chairs. So in between rotations and things like that, we had to address it. We just asked students, hey, you know, we need to be a bigger space here. But I think it goes back to the messaging we did when we started the class was we want you to social distance because it's for your safety and for your fellow classmates' safety. And for the most part, actually for the entire part, students were willing to do pretty much whatever we asked of them, including here as part of their lab, sitting in a mask and face shield for, I think, 3.5 hours, willing to do blood pressures, do assessments on other people, mannequins, things like that. They were willing to do that because they have this dedication to complete their program. This is a class that's been online up until this point until we were able to return. So we've had to extend them a couple of weeks to get them done, but they're at the point where they're just happy to be in the class and doing skills. So they're pretty willing to do pretty much anything that we ask of them. They've been happy to do it and work with us. So this was simple. We just had them sit far enough apart where it was 6 feet, and stagger the chairs in the rows and things like that.
This is another example of that. This is actually from Chip at Cape Fear Community College. He shared this on the Google faculty group. So if you're not part of that, it's a great place where there's tons of resources. But they did a similar thing where they taped off spaces 6 feet apart. And what you see is each student has their own kind of like pod with their own equipment, but they're gonna participate in a scenario together and with the instructor in the center being 6 feet away. So a lot of people have already come up with these ideas and have great pictures or examples of how you can implement it in your space. So I would say for sure crowdsource. This code links to the NEMSI's page where they've created an actual place for you to put your COVID policy resources up there. And again, shout out to Michael Nelson at a college I can't pronounce in, I think, Arizona, but he's actually put up some policies there. So we can already start sharing information. I've shared a whole bunch of stuff with you guys here on these slides. Happy to share more, but really you can adapt these ideas and these concepts to fit your local needs. One of the things that came up in the Society for Simulation, they also have interest groups where you don't have to be a member, but you can join and look at the forums that people are posting, was use of linens. So our school, we don't have a linen program, or we don't have a linen service that cleans our sheets. When they get dirty, I take them home and wash them, or we have students wash them for extra credit. So now we're thinking about, okay, well, if we can't use that much linen because every day we're gonna have loads of sheets to watch from the stretchers, maybe we're gonna specifically choose not to use that. It'll help with cost, and it'll help with just decontamination between groups. We're gonna make that an active choice though, and we're gonna explain that to students as why we're not doing that. And we could potentially have a dedicated time where we learn how to make a bed. Nursing does that. I think there's like 7 different ways to officially make a bed if you're an RN. But we could do something like that, and then that will help shed some of the cost or some of the concern around contaminated linens for us. We're gonna do something similar in the paramedic program with these multiple different pods where the students will work as a team, but 6 feet apart. And we're gonna use our iSimulate and screencast it up to the projector in our large room. So now all the students can actually see the monitor regardless of where they are. And that can hopefully help us with our team dynamics of looking, checking. If someone calls out the wrong rhythm, have a student intervene and politely say, hey, are you sure about that? Let's double check, and use that closed loop kind of communication, all of the sterile cockpit stuff from flights, right? Crew resource management kind of ideas. And that way they're not all crowded around a tiny monitor, which if you've taught an ACLS class, you know happens. Those shiny lights and beeps tend to draw everyone in, and then you're definitely not 6 feet away. So that's one of the adaptations we're making. We're just gonna screencast our monitor up to a large monitor or a production screen so everyone can see that. And we're lucky here to have a lot of iSimulates who thankfully they've sponsored this as well, but we can do that without having to worry about too much contamination with monitors or being really close.
And I would add, Katie, our students are aware of that and they're used to that because we've been using the iSimulates for the group learning online through our lectures. So they know exactly what's expected of them, and they'll see that coming up. It's a benefit of being able to incorporate what they had in lecture also into their skills labs. I would add, we're doing tape on the floors and things like that. What we've discovered is, well, a parking lot, if you have one that no one will get mad at you for using, makes another great source. Parking spots in a parking lot are about 6 feet apart, a little bit bigger. So you can put somebody in a parking spot, have the next parking spot empty, the next parking spot someone else. That allows your instructors room to move around and allows you to safely move about. So we have nice weather in California's case, so that makes it nice for us, but that's another great resource for you if you're like, gosh, how do I socially distance all of these people? Parking lots have come into play a little bit more than we have in the past.
So I thought we could answer some of your questions now. Jarell was asking about how we do skills remotely with multiple lab instructors. We are arranging, at least for the paramedic program, I think EMT is the same, as we mentioned, rotations. So one instructor with a small group, and then specify doors to rotate through. So we're still using multiple instructors with students. We had thought about like having one instructor with one group all day, but we really wanted to play to the strengths of our instructors, and we didn't want to minimize the learning. So if one group only got one person's perspective through the whole come back to skills, we thought that that probably wouldn't be very good. So we are going to have multiple instructors talk to the different groups, but we're going to work to try to rotate them through in a way that there's not a lot of large group interaction. So hopefully that answered your question.
And we actually do a wrap down at the end of each one of our skills days, where what used to be all the students came into one classroom and then the instructors just provided them, you know, a minute of like, here's the takeaway. Hey, we saw a bunch of this, or we didn't see this. Now the instructors rotate instead of the students rotating. So they stay in their room at the end. And then we've made it easy when they end at the end of the day, they come back to that same room the next skills day. So we have skills here going on this afternoon. They're not back until Friday. So they know if they end in room 301 or 302, that's where they're coming back the next day. It just makes everything run so much smoother when they know where they're going and where they're coming from, to limit the amount of people kind of hanging out in the lobby.
Yeah. So another question is, are our lectures online and only necessary to labs in person? That's absolutely correct. We're doing anything that can be done online. So we're not limiting that just to lecture. That also involves small group activities, whiteboarding, interactive. We've done simulations online. We did almost a full ACLS course online. So we're doing a lot of stuff online and really limiting the things that have to be done in person to in person. So the higher levels of the psychomotor skills acquisition and requirements and stuff that we have to get signed off for training that has to be done before students can move on in the program. Otherwise, it's all online. Sarah's asking about a policy for a medical exemption stating that they cannot wear a mask. No, we have no policy and no exception for the universal masking. I'm not sure what would potentially cause you not to be able to wear a cloth face covering and still allow you to be an EMS provider. One of the things that I think Michael mentioned in the chat was we require all of our students to be mask fit tested before they can enter the, well, while they're in the paramedic program, but before they can enter the clinical and field setting. So all of our students are required to be mask fit testing. So I don't think anyone would have an exemption to be wearing a mask, but that is definitely something you might want to look into if it's not standard in your program. Another question about cost. So definitely a concern, right? We're adding more instructors because we feel it's the right thing to do. And we feel it's the only way that we can continue offering the education. So for us, the choice really was don't offer any programs and our fixed costs aren't changing. So that would just be a complete losing money situation, or continue to offer programs with maybe more costs for staffing. And some of that is our programs that have moved online. We're using outside instructors who are part of our program, but maybe only taught once or twice a year. Now they're teaching more. So it's an increased cost, but we're still getting high quality education, and that allows our full-time people in LA to focus on the skills instruction here. So that's the choice we made, and we're kind of balancing that out. It doesn't mean that I don't get to buy new IV arms probably for a while. So I'll be making some with Smooth On for a while, but I think it's worthwhile for us.
I would say the same thing. We're just making the decisions on what needs to be purchased versus what doesn't need to be purchased. We may not get the new fancy equipment next year in place of other things, but I think everyone is probably in the same boat in terms of having to offset any canceled classes as well. You're forcing yourself to find those cost savings. Also, staffing is. We're bringing in staff a little bit earlier to help do temperature screening so that our full-time staff can stay in the classroom and, advocate for social distancing. So those are all things that we're going to have to try and offset.
And then Andrews asked us if we're concerned about ventilation airflow in our lab layout. Yeah, that's definitely been a concern for me. So looking at some of the early outbreak studies, like they saw at restaurants, if you were sitting downwind from the table that was positive, they were also getting infected as well. So the thought was to minimize the amount of time spent in a controlled ventilation area, I guess. I don't know if that's the right term. I'm definitely not an HVAC specialist, but so we're looking to have shorter time periods so that they're giving the rooms a time for any aerosolized particles or whatever to get dispersed or go onto the ground, and then we can clean them in between. So we have our buildings have housekeeping that have upped their wipe down routine and everything. So we're increasing the amount of cleaning that we're doing to try to help with that, and then trying to limit the amount of students in a room. So as an example, we have 100-person, I think it's 100-person capacity classroom, and we're putting 10 students in it. So we're just really trying to minimize any type of risk. And since we don't have potential to change airflow, and we're definitely not a clinical setting where the air is filtered, right? We're not a hospital. That's been one of our concerns, which is why we're keeping it to lower groups for smaller periods of time.
I saw in the chat, Bo asked, are we using ProctorU? We are for some of our high stakes testing. We did another webinar and talked about a few of the other resources that are out there in terms of doing other types of exams, using older exams, crowdsourcing exams when you can't ensure test security. For skills exams, I think those are the things we're recognizing. There are certain skills that we do want to evaluate competency on for certain people. And those are the skills we're bringing students back in to evaluate. So exams, yes, on ProctorU and some other ways, and then skills exams, that's why we really deemed it necessary to return to some small group work.
Yeah, and so here's our contact information if there's any additional questions that you need or any resources you're looking for. Again, we crowdsourced all this information from our partners and collaborators here at UCLA and on the paramedic faculty group and the FISDAP exchange and NEMSI's boards. So we're really happy to share the information we found from all these other smart people with you guys. And if there's any other questions, we're happy to answer them, but we're running up on the end of the time, so.
Absolutely. I want to thank both of you guys for that incredible presentation. This is super informative. I'll have this information included in our follow-up email that will go out, so everybody will be able to obviously go ahead and take a photo of this slide, but it'll also be sent directly to you so that you can have access to that. And then there was a question, I'm sorry I didn't have this information before the webinar began, but are you willing to make these slides public, and I'll just send them out to everybody in attendance?
Yeah, sure, that's fine.
Okay, absolutely. Then I'll distribute this presentation so everybody will be able to go back through it and look through, and then this recording will obviously be available on our YouTube page and on our website following this presentation. But thank you both so much for this incredibly informative presentation.
Yeah, it's our pleasure. Thank you for having us.
Absolutely. EMS is a team sport. We're all in it together.
Absolutely, I appreciate it. Thanks, guys. Have a great day.
You too.